So coming to the last case, most of these patients, my experience with this kind of TMAs are, in peripheries, when a patient comes with an AKI after a postpartum, the first common diagnosis proven otherwise is called puerperal sepsis. And these patients receive continuous antibiotic, and AKI has been linked to the sepsis. And when I asked oliguria without hypotension, they said, sir, leukocytosis tha, TLC was high. 14,000, 16,000 TLC count will be very common in a peripartum period after a cesarean section. And that, I asked, did you had any culture positive? No. No, sir, we took a high vaginal swab, it is positive. It's such a, you send a sample of drain, you will grow drain. So that's the story. So TMA is underdocumented, and it can be only proven after you actually do a biopsy, most of the times. So there was a debate on this from nephrology and all, and we all agreed for that overlap. And I will share you with a paper how these overlaps are very common and not uncommon in many situations. The last case, which was a historical case for us, it is, we send it to NEGM, and this is under review of a BMJ articles right now. And this is a story which Dr. Pawan was mentioning on the dais, a 33 years lady, a 15 weeks of gestation, a high profile family, came with a generalized clonic-tonic seizure at a 15 weeks at home. On the way to us, had a 2-3 more seizures, and the seizures continues. As expected, initially, the vitals were stable, there was no hypoglycemia, there is no focal deficits, lab and antenatal examination and fetal scan all were looking appropriate at that time. At this point of time, differentials, ma'am, 15 weeks of gestation, seizuring. Dr. Anita.
Early weeks, yes, we have to think in terms of TTPs or something like that, that's causing the insufficiency, central. And yes, it could be refractile epilepsy sort of thing that went undiagnosed, or any other medical conditions where meningoencephalitis sort of conditions, because we have to, as we learn from every session, that our options should be wide open, that anything can happen in any given scenario. So all the medical conditions also have to be addressed.
Ma'am, any other points? So 2 points, TTP, meningoencephalitis, seizures.
No, it's like this is a new onset refractory status epilepticus. Actually, you have mentioned there is no history of fever. We can think of all these febrile illnesses, infections.
So no meningeal signs, no fever, no.
And autoimmune. These are the things that we will be thinking of. Pregnancy-related ones specifically will come really late. 15 weeks, very, very unlikely.
Jayanti ma'am, anything?
The only thing I would like to ask you is, was she having intractable hyperemesis also? Because in those also you can get any of these thrombosis.
Lady had no history of hyperemesis gravidum.
And there's no history of headache, but if there was, then I would also think in terms of the, intracranial space occupying lesions.
Okay. So yes, obviously those all were there. MRV, MRI, which are commonly encountered phenomena, were normal. Continues to have a multiple GTCS as expected, received midazolam and levipil or levetiracetam in the ER, and then add on to have a phosphonitoin, phenobarbiturate, 4 or 5 anti-epileptics, infusions, midazolams in a loading doses, no response. Patient went on to had repeated episodes needing a intubation, mechanical ventilation, continuous EZ, high dose midazolam, suspected possibility of a ongoing encephalitis because we had no clue. MRI is normal, MRV is normal, patient is seizuring, and then the CSF analysis doesn't seem to have any meningoencephalitis. And this is the patient who actually
also think of cysticercosis, but you are saying the
yes,
MRI, everything is normal.
Normal. So in this case, later on, the MRI came, it's normal. So this we call seizures is one. Then we say status epilepticus. When you have a continuous seizures in between, you are not regaining consciousness, and the patient is having. Then we say refractory status epilepticus, where you are benzodiazepines, and add on to that your anesthetic agents are also not able to control. And then we say supra-refractory status epilepticus, when nothing is helping and the patient is seizuring, where we use a different kind of drug. This patient was on 7 to 8 anti-epileptics on injectable forms, on a midazolam, on anesthetic drugs like propofol and inhalational anesthetic, not responding. We used ketogenic diet, no, hypothermic protocols, and at the extreme point, the magnesium sulfate was also given. And this patient, at a point, after all this, when not responding in a week time, we spoke about, when we went back and looked at the literature, pregnancy itself as a fetus is a foreign body for any mother, can induce some amount of autoimmune phenomenon. And there were literature suggesting that the terminating pregnancy can be a way in them. So that was an ethical issue. So I'll take Dr. Anita ma'am's opinion on that. So will you consider it terminating?
So if pregnancy, I suppose, is a cause, then we have.
Don't know.
But I do not say. See, there is so much of immunological tolerance in pregnancy. If we are coming across some new knowledge that HLA class antigens are no more working, and immunomodulation is also, it stands to susceptibility after so many viruses interferences in our lives, then we have to be open to understand that such sort of things also might prevail. And I think the new book should open up for considering these as one of the indicators under the MTP rules, where that should be structured enough to consider it as termination for pregnancy.
So we took this into ethical issue. The ethical team was involved, and we got the literature on board, and we had a family interaction, shared discussion, and they said we want mother to be alive. Even there is a small risk that the fetus may be the reason, please terminate. So with that consent, with that approval, we could actually terminate this patient, but that didn't help. Unfortunately, that didn't help. And this is the PET-CT report. The CSF could not give anything. That is the PET-CT report. And the PET-CT could suggest us this is a autoimmune phenomenon of encephalitis. And this patient was altogether there for around 40 days plus in the ICU with endotracheal tube, tracheostomy, Foley's catheter, unconscious, deeply comatose. And after 40 days, this patient started weaning from steroids to IVIG to plasma exchange to immunotherapies. And after 40 days or 45 days, this patient didn't respond. So at that point of time, we again went back to the literature. And in these extreme condition of not status, not refractory, not supra-refractory, those who didn't respond, they tried about electroconvulsive therapy, which we use for a schizophrenic patients, has been attempted. And again, there was a ethical dilemma. We took ethical approval. We did electroconvulsive therapy. That is just like what they do in a schizophrenic patient, and those were 7 cycles were given to her, and she dramatically responded to all those electroconvulsive therapy, and this is not common. This is very, very rare scenarios, and in pregnancy, autoimmune encephalitis responding to electroconvulsive therapy is nowhere evident in literature. That's the reason this paper is still under the review, which they have initially accepted in British Journal of Medicine. Probably we will get through that as a part, and after 45 days, after this therapy, we could wean, we could decannulate, the patient regained her muscle power over a rehabilitation, and she's still coming back to us with on and off some challenges of memory loss in the early few weeks, but now she's back to her job. She's a healthy entrepreneur now, and giving us all motivation that we cannot lose this patient. They are otherwise healthy, normal. They should be back to normal. And with this, I thank all the panelists being here and give us, you can actually have a final comment. So we discouraged. I know.
Could we not send the placenta for molecular biology studies? Could we take the consent from the family to send this for further analysis?
I think the placenta was sent for
PCMB?
Yeah, I think so. And then the family was counseled not to have at least the pregnancy. That's what the instruction, the information from our OBG department at that time. Okay, with this, I actually, in the limitation of time, I thank all of you for this wonderful 20 minutes of wisdom sharing. Thank you, ma'am.